stream for us. Thank you. All right. Welcome to Public Health and Minority Health Disparities Subcommittee. It is February the 20th, 12:05, and we're going to get started. We've got a number of bills today, and we have a hard stop from one of our departments at 12:45. So we're going to try and get through these bills as best as we can. And we're going to start with House Bill 127. Erin, if you can walk us through the bill.
This is a departmental bill that establishes a non-occupational post-exposure.
I would try logging out and logging back in. I'm on a Zoom call.
Ms. Roche, you're
Roche,
not muted.
Could you mute? Thank you.
This is a departmental bill that establishes a non-occupational post-exposure prophylaxis standing order program. This bill was discussed in last week's subcommittee, and we did walk through the amendments. It was actually held because there were concerns from MCASA and the Hospital Association, and those concerns have been addressed in a new amendment. If you look, I did send a reprint, and in your reprint, page 3, lines 12 through 14, under the bill as introduced, the department was required to adopt regulations necessary for the administration of the program. And this amendment would also require the department to adopt regulations that address the needs of specific populations, including victims of sexual assault and pediatric patients. So that's the only difference between the bill that was discussed last week and
last week. Thank you. And this new amendment addresses the outstanding concerns. I have a hand from Ms. Horton. Did you want to be heard on this bill?
Yes, I would just like them to explain the amendment. We got it yesterday afternoon. I know they talked to Department of Health, but I just wanted to have context of how this would impact the bill. That would be appreciated.
Are you asking me or who?
No, I was hoping that someone was on the call.
I could perhaps provide guidance. As I understand this, and I think Jane also has her hand up, the goal of this would just be to specifically note that the protocols and regulations that we are working on would particularly take into account these populations that MHA and MCASA.
Just leave it on.
Okay, thank you.
Okay. Can I have a motion on the amendments?
Move the amendments. Second.
All right. Amendments have been moved and seconded. Any further discussions? Any other questions from the members? All right. Seeing none, they've been moved and seconded. All in favor of the amendments, say aye.
Aye.
Aye. Anyone opposed? All right. And
move the bill with amendments.
Thank you.
Second.
It's been moved and seconded. Any further discussion? All right, all in favor, say aye. Anyone opposed? Go ahead and raise your hand in the chat. I'll give everyone a moment. All right, House Bill 127 passes unanimously. We are going to turn to House Bill 177. As a reminder, this is the hospital's care of infants after discharge. We did vote on the amendments last week. We did not vote the bill. And my understanding is we had additional amendments that were consensus amendments. But if Erin, if you can walk us through the additional amendments. Thank you.
The only changes between the amendments that were presented last week and the ones that are before you today are that it's very clear that the educational resources that are provided will be both oral and written. It also provides that as soon as practicable before discharging an infant after the infant is born, that the hospital must ask the infant's parent or legal guardian to describe the sleep environment that the parent or legal guardian will provide at home, inform the parent or legal guardian of the importance of ensuring that the infant has a safe sleep environment and the risks of suffocation and sudden infant death in unsafe sleep environments, and that the hospital will document that the educational resources were provided. There's also language that on or before January 1st of each year, on or before January 1st of 2025, each hospital must establish a process for providing the parent and guardian with oral and written educational resources and the information required in the bill, and also must establish a process for a parent or legal guardian to confirm the receipt of the educational resources and for maintaining records of confirmations of receipt of those resources.
Thank you, Erin. And just a process question. Is this in addition to what we voted on, or is it, okay, so we can
It
just vote-
builds upon what was voted last week, so it's not exactly like what was voted last week.
Okay, but we can vote on these amendments. So if I can have a motion on the amendments.
Move the amendments.
Second.
All right, they've been moved and seconded. All in favor of the amendments, say aye.
Aye.
Anyone opposed, go ahead and raise your hand in the chat. All right, if we can get a motion on the bill as amended.
Move the bill
Move
as
the bill as
amended.
second.
All right, it's been moved and seconded. Any further discussion? All right, I have a hand from Delegate Hill.
Just real quick, I just want to clarify that as they develop, the hospitals develop a way of tracking that the information has been given and the people have received it, that's just for information purposes. So if people don't sign off, or there's an error, we'll just have information, or the department will have information about the number of people who never signed off that they got it, right? It's just information. To know if there's a problem with receiving it or anything like that, right?
That's my understanding. May I, Madam Chair?
Yes.
Yes, Delegate Hill.
I know these were consensus amendments with multiple stakeholder meetings, so.
Yeah, and there were a lot of moving parts, but yes, it's just information will be provided. And if you're curious, Delegate Hill, about determining whether or not there's an association between receipt of safe sleep education and infant outcomes, I am too, but I was advised that this bill is not the place to answer that question. Remember, we have a child fatality review board.
That they have,
Right.
we have information that we can determine down the future. The board can determine if there's a problem or not.
Right.
Right, great, thank
That
you.
answers your question. Thank you, Madam Chair.
Thank you very much, and thank you for the question. That was a great question. Any further discussion? All right, we have a motion on the bill as amended. All in favor, say aye. Anyone opposed, go ahead and raise your hand in the chat, and I'll give everyone a moment. All right, House Bill 177 passes unanimously. House Bill 103, thank you all for doing so much work ahead of time. Erin, if you can walk us through the bill. And I believe this one does not have amendments.
No amendments, correct.
Yeah.
The bill requires MDH to study the feasibility of including coverage with minimal benefit restrictions for removable full and partial dentures and reimbursement for providers on a per-patient basis for house calls and extended care facility calls under the Maryland Healthy Smiles Dental Program. The department must also study the feasibility of setting reimbursement rates for such services at amounts that ensure that all dental care providers are reimbursed adequately to provide access to care and are not less than 60% of the average commercial rates for all payers in the state who offer the services, or if average commercial rates cannot be determined, specified benchmark charges. And there's no fiscal impact on the bill.
Thank you very much. Can we get a motion on the bill?
Move the bill.
Second.
All right, it's been moved and seconded. Any questions, any further discussion? All right, all in favor, say aye.
Aye.
All right, anyone opposed, go ahead and Delegate Riley, you had your hand up. Did you have a question, or you just want to be recorded as opposed?
Sorry, I was on speaker. I'm sorry. I just came into the meeting and I
That's
had
all right.
another meeting. So I just need to know what bill we're on.
Absolutely. So this is House Bill 103. This is the Maryland Medicaid Assistance Program Dental Services Coverage and Rate Study. It's studying.
I'm good. Thank
Okay,
you.
you're good. All right.
Yes, thank you.
Thank you. House Bill 103 passes unanimously. House Bill 215. This is Human Services Attendant Care Program, ongoing additional supports. Erin, if you can walk us through the bill And this one has no amendments.
Yes, this is a departmental bill that expands the purposes of the attendant care program in the Maryland Department of Disabilities to include providing financial assistance to an eligible individual for ongoing additional supports.
Thank you very much. And if I can get a motion on the bill.
Move the bill.
Second.
All right, it's moved and seconded. Any further discussion, other than just noting that, we are thrilled to see our colleague, our, former colleague here, in subcommittee. Any further discussion on the bill? All right, all in favor, say aye.
Aye.
Any opposed, go ahead and raise your hand in the chat. All right, House Bill 215 passes unanimously. Because of their time sensitivity, Aaron, I'm going to say that we jump to 576 because I don't know if we have anyone here on 408, and that's my bill. So I'm happy to move that to the back so that we can hear from the department on 576, mental health emergency evaluation, involuntary admission procedures, and assisted outpatient treatment programs. For the members, we are being conscious of the department because they have their hearing on this bill in the Senate at 1 o'clock. So we want to hear from them to walk us through the amendments that we heard about in the hearing, but we did not have before us.
And I sent right before the meeting, you all got an email that has a reprint version of House Bill 576, which establishes the assisted outpatient treatment program statewide. It's a departmental bill, or I'm sorry, it's an administration bill, and Marie Grant is here to walk through the reprint version of the bill for you.
Great, thanks so much, Erin. And I don't know if everyone has a copy, I'll just step through my paper copy, I guess. Does that work?
I think that's perfect. Yep.
Okay, great. So thanks everyone. So first of all, we really appreciate all the work that's gone into this and with stakeholders. I will say, I see Judge Morrissey and Kelly on the phone. I do want to highlight that they have a couple of questions about notification that we have not answered yet. So those aren't incorporated into this draft, but I do want to make clear that we're still looking into those provisions. But this is what you have before you reflects the latest and greatest of everything we've been working on. So starting on the statutory text of the bill, which is page 3 of your reprint. As we mentioned in the hearing, there's really 2 sections to this bill. The first has changes to emergency evaluation procedures. The second is AOT. This first amendment removes changes that would have allowed a peace officer to transport to a nearby emergency facility rather than the nearest. That was something that I think we heard a lot of concern about from some of our healthcare provider colleagues about unintended consequences. On pages 3 and 4, still in the bill, are some changes to emergency evaluation procedures that give psychiatric nurse practitioners authority, similar to physicians. This is, they have authority in a lot of other places. We think this is a really important workforce position, provision, specifically as we expand access to crisis services. The next change in the bill at the bottom of page 4 is an amendment that would remove changes from the original legislation to the department's authority to require admission for emergency evaluees. I think we heard again from the judiciary as well as healthcare providers some concern about this provision. And there is some intent around flexibility, but we think we should save this for another time. And so we're offering an amendment to remove that change. So that's the emergency evaluation provisions. Let me pause there and see if there are any questions before moving on to assisted outpatient treatment.
Let me start with if there are any questions from the members on these changes. Delegate Hill.
Yeah, Ms. Grant, Secretary Grant, can you just go through that last part at the bottom of 4? I just want to make sure that I'm totally clear about what with whatever being removed, what does this mean is required or not required?
Okay.
Lines 23.
So getting rid of the changes to that provision. So if in an emergency evaluation situation, current law says if an examining physician, or we would add nurse practitioner to that situation, psychiatric nurse practitioner, is unable to have an emergency evaluee admitted to a facility, so that's like any of our private hospitals, the physician, or in this case, psychiatric nurse practitioner, has to notify the Department of Health. And then within 6 hours of notification, the Department of Health must provide for admission of an emergency evaluee to an appropriate facility. And that's current law, and these changes would revert back to the current law.
Okay, and so if we think back to where things were even 6 years ago, if the department still can't, that just means that they're in violation and there may be a court case or right? I mean, you can't make beds that don't exist, right? So this is the
Yeah.
standard, but that doesn't really do anything to ensure that we're able to meet the standard. Is that fair?
That's definitely fair, and of course, you know that all kinds of work going on in other places to try to address those issues. But yes, that's exactly right, Delegate.
Okay, all right. Thank you. Thank you, Madam Chair.
Thank you. Any other questions from the members on the emergency evaluations portion of the bill? All right, Ms. Grant, if you could continue into the assist to outpatient portion of the bill.
Okay, great. So moving on to section 2. So I'm going to start on page 5, and then quickly move on to page 6. So this section of the bill takes effect July 1, 2025. The first section here requires representation under an assisted outpatient treatment proceeding under the new provisions of the bill, but that can't be construed to prevent a respondent from retaining private counsel. Moving on to page 6, and this is where there's a lot of amendments to make sure that we're aligning more closely to House Bill 823 as it passed the House last year. So the first change about what harm to the individual means. The second change is a definition of serious and persistent mental illness. And in effect, these two changes end up tightening the eligibility criteria for an AOT proceeding. The next big changes are on page 7 to what a treatment plan has to look like. So a treatment plan has to include at a minimum, and here's places where we made a couple of changes in response to feedback from the advocates. So first, we say it has to include assertive community treatment services if clinically appropriate. I think that we heard from some folks that they really want to see these. I think we also have some feedback that services may not be appropriate in every case, and so we wanted to provide that insurance with that language. The next change is that in the bill as drafted, we said if resources permit services of peers, we heard that peers need to be part of this, and so that change is made in the definitions. The next big change is on in 10-6A02. This says on or before July 1, 2026, a county shall establish an assisted outpatient treatment program. I think that we heard from our counties, particularly from some of our smaller counties, that there may be a longer window needed to get this up and running, even though we're getting started in July 1, 2025. So that gives them a longer runway. Moving on to page 8.
Can I pause there because we have a question from one of the members.
Okay, sorry, thank you.
Delegate Hutchinson.
Thank you, Madam Chair. I'm sorry, Marie. I just was lightly distracted, and that was a question I asked in committee. Could you just repeat that county component, please?
Yeah, absolutely, Delegate Hutchinson. So on page 7, we're proposing to add language that says this, and again, this whole portion takes effect July 1, 2025. We're proposing to say on or before July 1, 2026, a county would have to establish a program.
And
So that
because of-
gives-
And because of the
Okay.
on or before, it doesn't prevent them from
Yeah.
establishing it before, but it just requires that they have an established program by July 1, 2026, which is
Yeah.
an additional year. Is that correct?
That's correct.
Does that answer your question, Delegate Hutchinson? All right, thank you. Okay, go ahead, Ms. Grant.
Thank you, Delegate Bagnall. So moving on to page 8. There are some changes in a couple of different places on the bill where we're allowing for in a petition for assisted outpatient treatment that it needs to be accompanied by an affidavit or affirmation. Instead of the respondent's treating psychiatrist, we put in a psychiatrist. The psychiatrist is still going to have to have examined the respondent within 30 days and have concluded that the respondent meets the criteria for AOT. But that was a change that gives some more flexibility, and Ms. Hopwood will keep me honest. I think this aligns to language from last year in HB 823.
Yes, we made that change last year. But...
Yeah. Moving on to page 9. We're making some, first of all, we're changing,
Ms. Grant, we
go
can't
ahead.
hear you.
Okay.
You cut out for a moment there.
Okay. How about now?
We
Can
can
you
hear
hear
you
me
now.
now?
Go ahead.
Okay. Thank you. Oh, I see Delegate Lewis has her hand raised, Madam Chair. I don't know.
Oh, thank you, Delegate Lewis.
Thank you, Madam Chair. Thank you, Secretary Grant. I just have a quick question. We know how extensive the physician workforce shortage is statewide. We have a shortage of psychiatrists statewide, and the shortage is more acute in rural areas of our state. I'm just wondering and hoping that 30 days is enough time to actually connect with a psychiatrist. On amendment number 6 that you mentioned, the affidavit or affirmation by a psychiatrist, any psychiatrist, does it seem reasonable that we can expect that 30 days is enough time? I also know some mental health providers have, 2-3 month waiting lists for new patients. So I just wanted to think about that.
No, I think that's a great question, Delegate Lewis, and maybe a question we can take to some of our stakeholders. I believe this, and again, I think Ms. Hopper will keep me honest, this may have been in last year's. Oh, go ahead, Delegate Olson, sorry.
Yeah, Delegate Lewis, I think from last year, the reason we came up with the 30 days, it was with the thought that they've already been seen by these people before the petition is filed. So this isn't for them like after the petition, this is pre-petition, that going along with the petition, they need a recent evaluation by someone. So normally they've been emergency petitioned probably a few times. So there's been a psychiatrist that they've been seeing, or they've been in active treatment and the psychiatrist is probably the one making it. But we did that 30-day time frame because the thought was within the last 30 days before you file the petition, you've been examined by someone. I don't know if that clears it up or not.
That helps. Thank you very much. Thank you, Madam Chair.
Thank you.
All right. So moving to page 9. This is section 10-6A04 starts to lay out those criteria or again on findings when the court may order a respondent to receive AOT. We make changes, first of all, with changing references from serious mental illness to serious and persistent mental illness, again, to conform to that definition. We also changed some of the criteria to align more closely to, again, House Bill 823 as it passed last session. We refer to necessitating inpatient admission to a psychiatric hospital for at least 48 hours at least twice within a 36-month period. We talk about an act of serious violent behavior or patterns of threats. Again, this aligns with what you all passed in House Bill 823 last year. And so in effect, we're tightening the criteria to make sure that we're really getting at folks who are really, really in need of this treatment. On page 10, we make some changes here about a history of treatment non-adherence. I think this is, again, we're going back to language that you all had in House Bill 823.
Can you find out what I voted last year on page 823?
Hey, Teresa, you're not muted.
Okay. So this can't be due to financial, transportation, or language issues in the immediately preceding 36-month period. Moving on to page 11. This 106A05 has provisions relating to the development by a care coordination team. Again, that's going to be overseen by a local behavioral health authority in our counties. They would need to develop a treatment plan and providing copy and writing to various parties. We're adding language here on page 11 that would say that a treatment plan developed needs to be recovery oriented and consistent with evidence-based and evolving best practices in the treatment of serious and persistent mental illness. And we're adding this language at the request of the Mental Health Association of Maryland. Moving further down on page 11, the care coordination team, rather than consider, needs to honor any advance directive in the development of their treatment plan. Again, this was an important change and aligns with language from House Bill 823 of last session. Beginning on the bottom of page 11 and then going on to the following page, we're adding the opportunity for a respondent to voluntarily agree to treatment plans and then a procedure for what happens if they voluntarily agree to a treatment plan. So I think other folks have heard, I know we've done a little bit of research in other states where there's this opportunity. This actually ends up happening more than half the time as folks do voluntarily agree to a treatment plan under these circumstances. And in this case, with this language, the care coordination team would need to provide the treatment plan to the respondent, the county attorney, and the Office of the Public Defender. Not only the treatment plan and the providers that are included in the treatment plan. On the bottom of page 12, or towards the bottom in lines 22 and 23 of that reprint in the new 10-6A06. This says that a hearing will only be scheduled only if the respondent has not agreed to enter voluntary treatment. Madam Subcommittee Chair, I see Delegate.
Delegate Hill.
Thank you. Love the voluntarily agree to treatment. What does that mean if the care team wants to change the plan and at that point the person says, this part I can't go, does the process start all over again? Or is there a rapid entry back into, if they get to a disagreement point, right? What happens then? That we don't have to start a petition all over and we refer them, or do we?
There is a process later on in the draft for a material change to the treatment plan.
Ms. Grant, I think Judge Morrissey may be able to help us with that as well.
Absolutely.
I hope I can help, and thank you. A 2506 dismissal is a dismissal on stipulated terms, so that it's dismissed, but it's there in the background. And so if someone says there's been some problem with that, they can simply ask for the case to be undismissed is the best way. That's not a proper legal term, but I think you understand what I'm saying.
Right.
So I
So
think that
so-
would be the vehicle they use.
Right, and then so by voluntarily agreeing up front, the patient does not lose their ability to dispute any changes that the care team might later want to impose. They're able to come back in because it's not really, it's off the docket, but it's not out of the court. It can be brought back relatively quickly by either party. Okay, thanks.
Thank you. Great question. And thank you, Judge Morrissey, for being here to help us fill in the gaps. Delegate
Madam
Lewis.
Chair, yes. Thank you, Madam Chair. To follow on Delegate Hill's question, maybe Judge Morrissey could also help with this. How quickly would that undismissal process work? I'm assuming the respondent, the patient is in court, offered the opportunity to enter voluntary treatment, on the spot says no. Is that how this is happening, how it's unfolding? Just help us picture it, because we don't necessarily know.
Well, we don't really have this right now. So the only thing we have right now is an emergency evaluation, and the individual doesn't necessarily have to be there. We're authorizing an individual, we're making a finding of dangerousness and suffering from a mental disorder, and then authorizing the sheriffs to bring them in for an emergency evaluation. We don't have this process yet, and that's typically on something like this. If there was a stipulated dismissal that the parties had agreed to a course of conduct and then that's changed, they would file a motion and we would set it in. I can't tell you how long. I'm district court, this is circuit court. Typically, we would set the motions in after 18 days, because you got to have people response time. It might be 30 days in the circuit court. It's been 20 years since I practiced there, unfortunately, so I don't remember anymore.
But that's still, thank you so much. That's still helpful, because what I know about the courts is what I learned on Law and Order. So I'm just trying to picture how this might work, right? So the patient is not necessarily before the judge issuing a voluntary, a statement of voluntary treatment. This person, respondent, could be out in the community somewhere outside of the court when this decision is made. I just wanted to make sure I could picture it.
There's two different ways I think this could come up. That one, that they could have filed this new petition for assisted outpatient treatment, and that the parties prior to the hearing date have worked it out and they submit a 2506 dismissal. And if that occurs in sufficient time before the hearing, you could cancel the hearing if the judge agrees that the dismissal is good, everybody's good on it. Or it could be there in court when they have the hearing. A lot of times, out in the hallways, that's where things resolve. And then they would come back into the court and you would go over the stipulated dismissal with everyone, make sure they're all in agreement, and then accept it, typically.
Thank you, Judge. Thank you, Madam Chair.
Thank you. And I just want to remind the members of two things. One, I have to let the department go at 12:45. But also, this is going to be a very limited population that will be eligible for AOT, and that we will go through a regulatory process, as well as one of the reasons that the administration brought this bill forward is so that there would be some centralization of the processes as well. And Delegate Alston, I saw your hand up as well.
Thank you. So what I was going to say is, under these proceedings, for Delegate Lewis, they would be in the treatment program, and let's say the doctor wanted to up medication and the respondent didn't agree, they would need to file, they being the whoever was representing the doctor or the treatment team, would need to file a motion to reopen the matter because it had been dismissed, and explain why the matter needed to be reopened. Then the defendant or the respondent, they would have an opportunity to reply. And if it needed to be expedited, they could ask the court to do it on an expedited basis. And I believe further in the bill, we actually put some time parameters in terms of how long these cases can sit. so that if someone is in distress or decompensating, we can get them in quickly. So you would have to file a motion to reopen the case, and it's already spelled out in the rules of civil procedure what you would do. And I can send that around if anybody wants to see it.
I'd love to see that. Thank you, Delegate. Sorry,
Thank
Madam
You're
Chair.
welcome.
Thank
Oh,
you.
no, thank you very much, Delegate Alston. And I'm going to go ahead and turn it back to the department. To the members, I'm not expecting that we're going to vote this today because, but this is really good conversation, so we understand how this bill has evolved since we had the hearing. Ms. Grant, go.
Thanks so much, Madam Subcommittee Chair. So I think we are on page 13. I think we had just gotten through page 12 and are on page 13. At the top of page 13, we're clarifying here that all rules of civil procedure apply to cases filed under the AOT program, full stop. So in the original bill, we said to the extent that they do not conflict with procedures or timeliness, and we're saying no, civil procedure, period, there. Moving down to the middle of the page. Again, we are broadening the psychiatrists that can present testimony. So it's not just the respondent's treating psychiatrist, it is a psychiatrist whose most recent examination of the respondent occurred within 30 days. I think our next change is actually on page 15. And this is under 10.6A08, and it has to do with the process for material changes to an order. We say that not later than 30 days after receiving a motion for material change and any timely replies to the motion, that's new language, the court must respond to the motion rather than hold a hearing. That if they can deal with it through motions, we're allowing for that. The next changes happen at the bottom of page 15 and page 16, and this has to do with progress. The changes align to House Bill 823 as it passed the House, and essentially at any time during the period of assisted outpatient treatment order and on its own motion, the court can convene the parties for a conference to review progress. So the other item that's added that I think was important and aligns with HB 823 is there's a clarification that failure to comply with an order of AOT is not grounds for a finding of contempt of court or for involuntary admission. So that's not to say that the other criteria for involuntary admission don't apply, but just that non-compliance with an AOT order on its own is not grounds for that. Moving on to the bottom of page 16, these changes have to do with continuations, and the changes align with again, HB 823. So within 30 days before the expiration of an order, the respondent's care coordination team shall provide the respondent with a plan for continued treatment if considered necessary. Moving on to page 17, and this is the reporting language. I will say that I know there was reporting language that you all in HGO had adopted that really aligned closely to what New York had for reporting language last year. I think we had introduced some different reporting language. The amendments you see before you tried to smush those two together. So essentially we're providing for broader reporting language, but wanting to make sure that that's de-identified, and also just clarifying that it's to the extent practicable, because we may not always have all of this information for everybody. So there's a change made in page 17, which is pretty technical because we're adding in demographics about folks who are unhoused on a following page. there's a strikeout of renewed orders because we're handling that differently with the amendments. We're adding back in the number of voluntary agreements made. And then we are listing out the demographic data that we want to collect on a de-identified basis, again, if we have it. And then we're also adding in information on diagnoses of AOT recipients, as well as results from a use of a clinically validated symptom tool to assess responsiveness of respondents to treatment. Again, de-identified results of a survey of respondent satisfaction. And I think I got through all of the amendments.
You did, and I know you have a hard stop, Delegate Hill. I'm going to call on you, but I'm also going to make sure that the department can go and get ready for their bill hearing. So go ahead.
Real quick, just on the report, when we're talking about the number of times that the respondent has to apply with treatment, the information we get determines what we can do with it. So is there value in knowing the number if we don't know the reasons? There's a difference between a voluntary agreement to go from 3 times a week to 4 times a week. Then I'm going to accept a change in medication, right? There are some differences. So is there any additional information we would want to know about the nature of those treatment plans, or it really doesn't matter?
So that's a great question. I think we would want to know some information about the treatment plans. I'm just quickly skimming to make sure that we are not losing any of that. And I don't.
You may not be able to do it right now. I'm just saying that, again, getting numbers without substance often sends us in the wrong direction. And what we really want to know is if we're being fair to the respondents or the patients, and if we're being successful. And, so somebody who agrees all the time, that's a great thing. But maybe somebody who is protesting has good reasons to protest. Maybe they have a lot of allergies and they can't just take any medication. So that's all. So just something to think about.
Yeah, absolutely. Thank you,
Thanks,
Delegate.
Mike.
Thank you, Delegate Hill. And as I mentioned to the members, we're not going to vote this today. This was just our opportunity to walk through the amendments because I know there's still some discussion that is happening. Thank you very much to the department. Please go and get ready for your bill hearing because they are. So this was good practice for your hearing. Thank you. And to our members, we're actually going to try and have a second subcommittee this week just on this bill, so that we can have the discussion on the amendments. So I'm gonna hold the vote on this so that we have a little bit of an opportunity to digest what we just heard. We have one more bill, which I think we can get to and through, and then I can give you not much time before our bill hearings. So thank you very much for all your questions. And we're going to turn now to the last bill for today, which is House Bill 408, Mental Health Law, County Mental Health Advisory Committee's membership. We did not, we considered an amendment, but with further discussions with the Senate and with a concern for some of our smaller counties, we wanted to leave it flexible because some counties may not be able to provide a provider that has this expertise. So Erin, if you can talk us through once again what the bill does, and then we can open up the discussion.
The bill adds a member with experience with mental health care for veterans or individuals serving in the military to the list of persons that can be appointed as a voting member to a county mental health advisory committee.
And we did clarify that that the bill does make it clear that this is adding a member, not that you can sort of go from the existing membership and try and just look for someone who qualifies. Is that correct?
I think it makes it clear that a veteran or someone serving in the military has experience with mental health care should be considered. It does at least separate that individual in statute.
Thank you very much. Can we get a motion on the bill?
Move the bill.
Second.
All right, it's been moved and seconded. Any questions? Any discussion? All right, seeing none, all in favor of, I don't have it in front of me now. Sorry. All
408.
in favor of House Bill 408, please say aye.
Aye.
Any opposed? Go ahead and raise your hand in the chat. Thank you to the subcommittee. 408 passes unanimously. That concludes our work for today. You all are amazing. Thank you for all of your hard work and for doing your homework. And just listen for announcements. We're going to look at the schedule for later in the week so we can drill down on AOT. And I will see you all in committee in 9 minutes. So thank you. This concludes our subcommittee for today.